Move on to our next speaker. Dr. Aarthi Agrawal is going to be speaking on my first Phakic lens.
Hello everyone, a very good morning, and thank you Dr. Zain for inviting me and letting me share this first experience for my Phakic IOL. So this is back in 2016 when I started my practice. Just 2 months into my clinical private practice, I come across with this patient. Young female, 24-year-old, quite motivated because she was wanting to go for further studies abroad. So she came to me for a refractive opinion. Refractive error very high, as you can see, -9 with -2.5 cylinder in the right eye, with Phakic of just 438, with good anterior chamber depth, likewise in the left eye. So straightforward thing, that refractive error is high, pachymetry is low, good internal anterior chamber depth. So when we are talking about planning a phakic IOL, one thing is we are checking the internal anterior chamber depth, that is from the endothelium to the anterior lens capsule. And then, so it was a straightforward case. I went ahead discussing her options for phakic IOL. Back then in 2016, we did not have RIL. We just had the options of ICL, IPCL, and biotech Acriel. Due to the cost constraint, she opted for IPCL, and that was something which I was quite apprehensive, because back in my fellowship days, I had only done ICL. So for me, it was a challenge to do an IPCL. So this is just an illustration, because back then in 2016, we didn't know that mask has to be used even outside the operation theater. Like any of us, the first case, we are going to do over-counseling. So I counseled the patient about all the risk factors, everything which was involved, what I expected out of her, what she needs to expect out of the lens. And then she decided to move ahead. So this is my normal protocol, which I'll be discussing very quickly, how I proceed with the phakic IOL in my center. So I have made this chart which helps me not forget even one single point when it is, because it's an extensive workup which you need to do. Going stepwise, first important thing for any surgery is to rule out any extraocular defects, especially in high myopes. There are possibilities of phorias and tropias, so this is something which we need to see. Very, very, very important in any refractive surgery is to do your own refraction. This is one thing which will really take your refractive practice a notch higher. Do your undilated as well as your cycloplegic refraction only by yourself, and do not trust any optometrist. A good slit lamp examination to rule out if there's any cataract, that is one of the very important thing to document. Of course, along with cornea, how clear it is, and the other anterior chamber and other details of the eye. Very, very, very important in refractive as well, especially when we are dealing with phakic IOLs and high refractive error, is checking a detailed retina examination. If you're not very comfortable yourself, go ahead, referring the patient to a retina surgeon, which I usually do in my clinical practice. If the refractive error is more than -8, before going ahead with any kind of refractive procedure, I take a retina opinion on paper. So then comes the evaluation of the lens. So optical biometer is one thing which we need to do for white to white, of course, for the anterior chamber depth to reconfirm, and also for the keratometry and the axial length, because these patients later on, when they come for cataract, it becomes easier for us to manage and calculate the IOL. So here, although I had a pentacam, I still did Cirrus, because Cirrus, I like to do as many as investigations for my white to white calculation, so that my IOL, my phakic lens power and the sizing is, doesn't go haywire. The most important step is to do your white to white calculation by using a digital caliper, because of course your optical biometers and your topographies will give you a white to white, but it's always a good habit to do your digital white to white calculation, and then match it with your other parameters. For me, I always do my calculations myself. I although give it to the company person also, but I make sure that I'm doing my calculation myself, because especially when we are doing digital caliper calculation, we are not taking only one reading, and we are taking multiple readings. So what I do is I feed each and every reading and see how my sizing is going up or down. If suppose it's your first case or you are not very confident, go ahead giving the parameters to the company person, and they are fairly doing a very good job, because till now I have not had any discrepancy. For this case, it was a very fairly simple, very straightforward case. I went with sizing 12. Coming to preoperative, most important, like Dr. Zen said, that marking in sitting position is very important, even if you're not doing a toric phakic IOL, because when you're doing a phakic IOL, your calculation depends upon your incision. So irrespective of whether it's spherical or a toric, marking is very important in sitting position. I'm more comfortable using a mercury marker, so that's how I do it in my practice. One can also do a slit line marking. So coming to the loading of the lens, so first thing is, whenever we are doing a phakic IOL, we are loading the lens first, rather than we are operating on the patient first. Why so? Of course, in IPCL, we have a backup lens, but it's always a good habit, because it's a premium surgery, young patients. You don't want to make an incision and then load and see that you have a disturbed lens architecture. So always a good habit that you load the lens and then you start with the procedure. Loading of an IPCL is fairly simple. It's just like any plate haptic PCIOL. Very important thing is, don't completely fill the cartridge with visco. Partly with visco and partly with saline, because if the cartridge is filled with excess amount of visco, it can lead to flip. Step 2, what I do, this is my personal customization, because I had 2 flips of IPCL, so that's when I decided, because there are so many holes, there are identification hole, aqua port, and then you sometimes have air bubbles, or sometimes you have visco bubbles. So when the lens is unfolding in the eye, it becomes really difficult to identify where your leading hole is. So what I do is, just using a little marker on the right upper side, I just do a tiny marking, so that when my lens is unfolding in the eye, my concentration is only on that ink mark and not to see which hole I need to follow. Step 3, just like any PCIOL, like I said, plate haptic, you go ahead loading the lens. It's the most simplest way of, the most simplest phakic IOL to load is IPCL. Coming to the surgery, of course, doing painting, cleaning, draping, explaining the patient, putting good anesthesia drops. Important for this is, we need to take 2 side ports 180 degree apart, because this is very convenient for maneuvering. Main port, we've discussed in details how to do it. Coming to the surgery, be very generous in using viscoelastic, because we don't want to touch the anterior lens capsule. So like you see now, and phakic IOL is not done wound assisted. You have to go inside the wound. For IPCL, you can make 2.8. For ICL, you need 3.2 incision. So now you can see, if as my lens is unfolding, my concentration is only on that mark. So this makes your surgery very easy, and especially when you're a beginner, this is a very good thing to inculcate in your practice. Just one tip here I'll give you all is that when your lens is unfolding, so when you are halfway through the lens is out in the anterior chamber depth, just take a second or two, see how the lens is. If in case it's flipping, you can still at that time also reflip it. Then go 25% and then the last 25%. So if you go in stepwise manner, you will never land up in any problem. For a phakic lens, we all know
Dr.
that...
Aarthi, we are running a bit short.
Yeah, I'm just in my last slide. Tucking is very simple. I'm not talking detail about it. So thank you. So this is actual patient back in 2016. She was very happy, and the journey of phakic lens does not conclude at just completing the surgery. It actually begins from there, where you have to actually check the patient posture, vaulting, and IOP. Thank you. Thank you so much, Dr.